This is the Mechanical Care Forum, episode 394. It's season 13, and we're highlighting the McKenzie Institute International Diploma Program. We're checking back in with my fellow candidates in this 2023 cohort about midway through the theoretical portion of the diploma program. We'll hear about how they're coping, what they're learning, how they're balancing life with the demands of the study, and its impact on their clinical reasoning. This and more this week on MCF. Hey everyone, welcome back. Thanks for joining us today as we continue to explore the McKenzie Institute International Diploma Program this season, season 13 of the podcast. This episode is brought to you by the McKenzie Institute International. If you don't know, the McKenzie method of mechanical diagnosis and therapy is globally recognized as a leading treatment for back, neck, and extremity disorders. And personally, MDT has made the single greatest positive influence on my practice, hands down. The McKenzie Institute International offers this diploma program we're highlighting this season to those professionals who have achieved prior certification in the method. The diploma program is the pinnacle of MDT training. Successfully completing the diploma program will place you amongst the world's elite in mechanical diagnosis and therapy. If you're interested in learning more, here are two ways you can. First, stay tuned to today and be sure to be following us all along through this season, season 13, as we highlight this year's cohort of students through the program and get perspectives from this year's students, as well as from some of the instructors, from some of the clinical tutors on the clinical residencies, and more. And second, be sure to go to the website to learn more about the program and how to apply. You'll find that by clicking on the Education tab and scrolling down to International Diploma. Just go to McKenzieInstitute.org. Okay, so let's get to it. We're continuing today with a discussion with Ruchi, Tina, Tim, Davide, and Emily. We'll hear from them about how they're doing, now several weeks into the program, what they've been accomplishing, what it's like managing their life and work with this added responsibility, and how it's affecting their patient care and clinical reasoning through this theoretical portion. Stay with us through to the end to hear what's in store in future episodes. So here we go, episode 394. Enjoy. So with us today on the Mechanical Care Forum, we're pleased to welcome back to the podcast for kind of a mid-theoretical portion discussion, Emily Dabrowski and Ruchi Jain. Emily, Ruchi, welcome back to the podcast.
Hi.
Thank you. Thank you.
Absolutely. So glad to have you guys hop on kind of a mid-theoretical portion, a little more than mid. Actually, it's hard to believe it's more than halfway through, but just thought we would chat for a moment about kind of how things are going, what you're learning, how you're adjusting, where your mind is now with your clinical work and how you're seeing it maybe impact your clinical reasoning with patients. So Emily, again, you're in the northeast of the U.S. Ruchi, you're in India, in or near Mumbai. Is that right? Yeah. So we talked to you guys maybe the first 2-3 weeks of the program. We were all kind of green and unsure about how this was going. We were trying to get in our heads how we're going to sort out our day. Tell us, just from your perspective, Ruchi, how you're coping with all the demands of the program over the last 4 weeks or so since we've last talked.
So to be very frank, initial weeks I was struggling, but now I'm enjoying. I'm enjoying the clinical reasoning part. I'm enjoying treating my patients with that. I'm applying all that. I'm enjoying and trying to be a part of the entire diploma group.
Yeah, awesome. Yeah, good. So it's kind of the pressure's a little off and you're just enjoying the process. Yeah. Emily, the same, or tell us about your perception right now.
Yeah, I mean, kind of like I said, the first time around, it was nice to have just some inside guidance on just how to plan out my day from someone who went through the program last year. So having a couple sets of time throughout my workday is really helpful. And then having some time in the evening is helpful too. So 3 hour and a half chunks just to kind of just sign on and just stay current with what people are talking about has been really helpful for me. So I don't think I've changed my organization skills all that much since I first started week 1 and week 2.
Yeah.
And then applying them to patients a little. I think what I found the most changing was the lumbar SI joint week. I think I felt much more confident and cleaner in assessing lumbar spine first, checking flexion before going on to the SI joint. I may have then diagnosed an SI joint prematurely because I was so excited about it, which happens. Then I've come back full circle. So now I feel more, just confident in how to differentiate the two. But, honestly, I've learned a lot so far. A lot of the clinical reasoning I think I knew just from trainings I've gone through before. But I think what I've gained the most knowledge in is just what the literature shows on, or the lack of what the evidence shows on what we do in the medical field, from not only physiotherapy, but also just the ortho docs and primary care docs. So it's more kind of geared my mind towards now, okay, so what do I do with this information? How can I sort of empower those physicians that are maybe interested in learning? How can I empower them on just better discussions around imaging findings, maybe better assessment tools that they use before they send their patients to us, more just being more knowledgeable of everything that's out there and how to better communicate with my colleagues outside of physiotherapy.
Yeah, Emily, refresh our memory on your setting. Are you near doctors? Are you in a system with multidisciplinary? Yeah.
Yep. So I'm part of like a 50 to 70 person rehab team in a hospital network, and we're spread out over maybe probably 6 or 7 satellite clinics. My satellite clinic is in a primary care office under our hospital umbrella. So in my building, we have 7 primary care docs, one of which is a sports medicine doc. And then our main clinic, where I also used to be right attached in the same building, are our orthopedic surgeons and podiatry and everybody else. So we're really pretty close to all of those referring providers, not just primary care, but also the orthosurgery folks and the spine docs. So we're all kind of right there. And of course, we all speak different languages a little bit. The orthopedic special tests are used a lot more, of course. So it gets a little bit interesting when we're learning all this evidence and it's just not being practiced.
Yeah. Emily, tell us, are you in 100% patient care, or you have any admin or kind of oversight responsibilities?
No, 100% patient care right now.
Yep. Okay. Yeah. Yep. And so you're in the midst of it all day. And you mentioned that you were, based on your connection with this other clinician who went through the program a year ago, remind us how you blocked out your day with the diploma work.
Yep. So I've blocked out about an hour and a half twice a day for each work day. So I've kind of increased the hours that I'm in the building, but I've cut down my total hours by maybe 5, so that I can do those 2 hour-and-a-half chunks.
Okay. So you've got hour and a half in the morning, hour and a half midday. And then when you come home in the evening, you're getting it then.
Yep.
Yeah. Okay.
So usually like once I get home, I kind of do my own family life stuff. And then kind of once the kids have gone to bed, then I can get back on the platform and then start discussing stuff then.
Yeah.
I kind of take a break in the evening.
Yep. Got it. Okay. All right. Ruchi, talk about your pattern again. You've mentioned it to us a few weeks ago when we were connected, but remind us and then let us know, have you adjusted that at all?
I have a personal clinic. I am not attached to any of the hospitals right now. So I can adjust my patients now. I'm keeping it on appointment basis only. So I'm trying to keep my afternoons pretty like for 4-5 hours at a stretch. I can sit and read or discuss or comment on the group. So right from say 1 in the afternoon till 5 o'clock, I am busy studying with the schoolology, and mornings and evenings I am occupied with the clinic work. And later at the night part, at maybe 8, that's my last patient. Suppose that sometimes I sit again.
Yes. Okay. All right. Emily already talked a little bit about some of the things that she's adjusting with her patient care and jumping to SI joint perhaps a little early on an occasion or two. Ruchi, talk about what you've learned in the last few weeks. And maybe you alluded to it right before we started recording about how you're maybe applying it to your patients. Can you share that?
Okay, sure. So the last few weeks, I was applying MDT initially, but I was more confident with the spine patients, per se low back pain patients and cervical patients. But with extremities, I was not sure like what should be ruled out and when should I move to the extremity, per se shoulder, elbow. Though I got results with 2 of my tennis elbow patients with cervical source and few with shoulder as well. But this week got me more clear, like over weeks, and especially the 8th week on extremity, that got me more clear, like when should I move from cervical spine to thoracic spine to the extremity, and what baselines I used to miss initially. Like I never focused on looking for the cervical range of motion much. Many a times I like mild, moderate, maybe whatever it is, I was just noting it down. But right now it is mattering to me whether it is minimal or moderate or major, and whether it is only in flexion extensions or rotations or lateral flexions. So all of it is definitely helping me to be better, and I'm trying to get better.
Yeah, fantastic. And you briefly mentioned an actual patient that
Yeah. So
you applied some forces, I guess, to the
So
thoracic spine?
today there was a patient who came with complaints of base of the thumb injury, and she got her X-rays along, and those were negative. She went to a physician, an orthopedic, and the trauma happened 1.5 months back, and the physician has just given some tendocare medicines, some painkillers, nothing else, and asked her to do some ball squeeze exercises just to strengthen. There was no swelling present, there was no redness, there was absolutely no signs of trauma which was present, and I don't know, looking at her posture and with the weeks and the readings which I was doing through the literature, I thought of looking at the cervical spine. And somehow, with just retractions, her pain disappeared at the extremity. And we rechecked the baselines for the thumb, and she was very happy in the end, just with the first session. And didn't take much time as well. It just took 20 minutes of my job. Maybe I would have spent more time explaining her, but this got me very faster and quicker.
Okay.
Which earlier I thought that would take more time.
Yes. Yeah. Ruchi, you had been seeing this patient before today.
No, this was the first session.
First session. Okay. And so she had this kind of base of the thumb pain.
Base of the thumb trauma.
Nothing else in the arm.
Nothing else.
And there was
no range of motion was affected at the wrist. There was nothing at the thumb. Her strength looked fine. Everything moved normally. But something, cervical ranges were reduced, especially retractions. Extension was major loss. The rotations were moderate loss. Lateral flexion was moderate loss. Flexion was still complete.
Okay.
But, and that is how she responded.
What was her age, Ruchi?
Her age was 47, maybe.
47. Okay. Yeah. Roughly. Yeah. So middle-aged. And you're thinking in your mind the Rastogi paper, I'm assuming, in those 5 indicators? Yeah. And so I'll put you on the spot here. What are the 5 indicators?
The 5 indicators would be presence of paresthesia. The second one is going to be if there is a range of motion restriction at the extremity, or there's range of motion restriction at the spine. 2 of them, two more indicators.
I'll help you. If they complain of symptoms changing in their history.
Postural change.
Yeah, that's right. And so in the physical exam, if you get a change in their symptoms distally with posture change, but also from their history, if they describe their symptoms are worse when still or with rotation of their neck or neck movements. So, all right. So sorry to put you on the spot. Don't worry. I'll put Emily on the spot in a moment. And you guys can put me on the spot too, I guess, to only be fair. So you found, and you may not have looked at the cervical or the thoracic spine in previous weeks or previous to the theoretical.
With a thumb injury, I wouldn't have thought of looking at the cervical spine. Not at all.
Yeah. And you got full abolished symptoms with that.
Yeah, that's my provisional diagnosis, that she is a patient responding to cervical spine retraction exercises. But let's see what happens with the follow-up.
Right. Because she's got to reduce and maintain, right? So we understand that you can kind of confirm that. Excellent. So way to go. You're already applying it. Nice job. So that's just an example of how your clinical reasoning is developing. And Emily, you alluded to it a moment ago as well. What else do you see in your thought process, Emily, with how you're addressing your patients or how you're thinking through while they're giving you the report of how things are progressing or failing to progress with patients kind of on the side as you're going along?
It hasn't changed all that drastically,
Yeah, that's fine.
Like all the training I've been through and kind of building therapeutic alliance, understanding black flags, yellow flags. I feel like I've been through a lot of training that I don't feel like it's drastically different.
Yeah. And that's fine. I've recently, just to let you guys know, I've recently talked to some recent graduates who are diploma now, and they've gone through, of course, the theoretical and the practicum. And some of them mentioned that it's more on the practicum for them when they saw the largest growth.
That's what I think. Yeah.
Okay. You're anticipating that. Yeah. Ruchi, do you see other aspects of when your clinical reasoning has changed, or an example of that just based on the first 8 weeks here?
Definitely, my confidence when discussing it with the other medical professions like orthopedic spine surgeons or any ENT specialist. Like I had a case of a patient coming with dizziness.
Yeah.
And somehow we ruled out that it's because of the neck. It was cervicogenic, and she was responding to sustained retractions maintained in prone lying. So with such a patient, though she was asked to get an MRI done initially, which is not required that time, as I knew from the papers that we can't correlate that well. But but at least that gave a question mark to the orthopedic surgeon who requested for an MRI. And he was like, yeah, maybe we didn't need an MRI. So I was able to convince him that.
Okay. All right. Fantastic. Yeah. So maybe just your confidence that you can you're coming to this conversation with another medical professional with some reasoning behind your thoughts or your opinions.
Yes.
Okay. Yeah. All right. So if you guys think back to before we started and you had hesitations or thinking, gosh, can I get this done with a family or just while I keep my practice going? What do you wish you had known before you started now that you've been 8 weeks through? Emily, you have thoughts about that?
Again, like I said before, I think I had a nice advantage.
Yes.
I think if my friend hadn't kind of told me that plan, it could have just been a mess, trying to manage hours and home life. But I think just having that breakup throughout the day has been helpful.
Mm-hmm. Yeah. Ruchi, you agree? Was there anything that you would look back now and think, I wish I had known this?
I would say maybe how to correlate with the literatures and, apply it on each and every patient of mine who got discharged and who took way longer than I thought. And the number of sessions are reducing. Like in India, the patients pay for themselves. We don't get any insurance.
So you're meaning you wish you could roll back time and see some of those patients again. Yeah. Okay. Well, I think we can all
save some money for them.
Yes. What do you wish you had known about the diploma program before you started, now that you've been several weeks into it? Is there anything that you thought, boy, I wish I had understood this or had a better knowledge about the program itself?
Like per se with MDTing, I was applying and I was getting my doubts cleared. But yeah, now I have a platform where I can put things very easily on Schoolology. If I have doubts, and I can share it with you guys, any of my candidates, and that makes it easier. But not that I would say that anything which I was not doing before. I was trying to get in to know the system much better before the diploma program as well.
Yeah. I think I have a project that we're meant to be preparing kind of slowly and gradually as we approach the end of this theoretical. Have you guys thought about patients that might be good potentials for that presentation, Ruchi?
Yes, I had 2 of my tennis elbow patients who responded to, again, cervical spine. Okay. So for one, I had to move locally since the symptoms plateaued. That was my first patient at this clinic.
Yeah.
That was 1.5 years back. And the second patient came after 6 months, Aarti Dikshit, and again, similar complaints. And for her, we were able to rule it out just with the cervical spine, and we didn't have to move locally.
Gotcha. Okay. Yeah, this sounds interesting. Emily, what about you?
Yeah, I've got a patient who had onset of shoulder pain after a pacemaker implant, but not for like a few months post. There's no mention of cervical spine. There was no significant neck pain. It was just shoulder. So he was referred for the shoulder. So after screening the cervical spine, even his left anterior chest pain that maybe they thought could have been from the pacemaker, that actually resolved as well. So it's just seen that there could have been some chest pain, not pre-pacemaker, he clearly needed one, but just some of the aftermath symptoms that maybe could have been attributed or chalked up to just, that's normal, actually resolved by cervical spine motions.
Yeah, kind of the integration of this to address some of these medical complaints outside of true musculoskeletal is pretty fascinating. Makes me think of Vikas Agarwal, who's that internal medicine doctor in the middle of the U.S. who's applying this in an internal medicine setting. So good job on that. That's excellent. Any last thoughts before we wrap up, kind of mid-theoretical and then just preparing? We might try to connect toward the end once we've completed that you guys feel like is something that's in your mind, at least from this mid kind of portion here. Emily?
Well, one thought that I had, of course, me embarking on this, I was kind of apprehensive with a family, 3 young kids. I just didn't know really what the best time would be. There's really never a great time, I'm sure, with families or with other commitments or whatever it might be. But, I was thinking it's not that impossible. I've got 3 boys under 6, and that's pretty insane. I'm not sure I get through my day on a regular basis anyway, But I think as long as you have the slight flexibility to cut your hours down and spend a few more hours at work so you're away from your family, because you can't do a lot of the stuff when you're home. I mean, it's too hard to multitask when you've got kids that need that much supervision. But I think as long as you can just chip away at time outside of the household, it's very doable. And even the past couple of weeks, I cut my hours down to 32. Like normal for me is 36. I've even added a few patients back in because I feel like I had a couple hours where I could sneak in some acute cases. So I'm not drowning with trying to manage 3 young boys and a house and still a semi full-time job. So whoever thinks that's a roadblock, I can assure you it's doable. I'm not saying it's easy, but it's definitely doable if you just kind of keep a routine and stay efficient.
Yeah, and from one of your classmates, I'll tell you right now that I see you in there a lot making comments. So I know that you're purposely just jumping in, reading on some other comments, commenting, and I know that you've read this stuff. I know you're jumping on that real quickly and staying on top. So it shows you're demonstrating it, I think, fairly clearly.
One quick thing too is, for people that maybe are listening to this that haven't done the program yet, there's a lot of great discussion. I went to bed 2 nights ago and I didn't get onto the platform till probably maybe around lunchtime, and there were like 100 posts. It was a little overwhelming to be like, all right, I'm going to go to a corner and read through about 100 different posts in the past 12 hours. But it's just nice to hear so many different thoughts, people that are living in different countries, different kind of clinics. It's really valuable information that you get from the program.
Yeah, and I think until you experience collaboration like this, you don't realize what you don't know, that maybe you're not tapping into and not, I guess, taking advantage of what collaboration can do for your progression and your professional development. So it's a good point. Ruchi, what about you? What are your kind of just last thoughts here before we wrap up today, just mid-theoretical?
I'm actually waiting for the coming weeks. How are they going to be?
Yeah.
As week by week, things are like the load is increasing, but we are able to cope up with it. The comments and the scrolling down the phone has increased a lot because there are a lot many comments compared to the previous week. So yeah, looking forward for those weeks, but at the same time, a bit apprehensive with the practical component. Like, how is that going to be?
Yeah. Yeah. And when I think, Emily, you had mentioned you're around September through November. What about you, Ruchi? Have you identified the time?
I'm there for next year, April to June.
April of 2024.
Yeah.
Got it. Okay. Yeah. Well, that's good. It gives you plenty of time to plan for that, right?
Mm-hmm.
Yeah. Excellent. Well, it's been great to catch up. Thanks for being willing to do this. We'll catch up perhaps down the road a few more weeks. Appreciate what you guys are bringing to our cohort and also to the podcast today. Thanks for joining us, Ruchi and Emily.
Thank you.
Thank you, Jason.
Good luck to you too.
Yeah, thank you. So that's a bit of an update from their perspective. Let's switch over and hear more. So with us back on the podcast for another little touch during the mid-theoretical portion, Tina Olson. Tina, thanks so much for taking time out of your schedule and getting us up to date on where you are and how you're coping with all of this in the theoretical part of the diploma program. Thanks for joining us.
Yes, sure.
So Tina, talk to us a little bit about it. It's been a few weeks since we were back talking before, early on within the first week or two, I think, of the start of the program. We're now several weeks into it further. Tell us how you're doing overall, just in general terms. Are you coping with things all right?
Well, I'm still sticking in there. And yeah, I'm coping with it, and I kind of got used to it now. And yeah, I work like every morning, and then I study every afternoon and some of the night as well till around 9 o'clock every day. And yeah, I got a habit about it now.
Yes.
Getting used to it. Yeah. Yeah. So yeah, it's nice, but also I think almost every day I'm having ups and downs with the studying, because some of this stuff is really exciting, and yeah, I'm happy with working with it. But then again, some of this stuff is tough, and I have to use a dictionary quite often, and yeah, it's just a little bit annoying that I cannot just go and read away.
Yes. Yeah. So specifically in your situation and a few others, English not being your first language and having to do all of this in English, I'm sure adds just another element of difficulty. So I admire you guys who are having to do that. Can't imagine doing that myself. But so talk to us a little bit about any type of pattern that you had in the first week or two attempting to, address these things at certain times of the day or in ways that you were doing it early on? And have you changed any of those things, whether that be how you read or when you read, or are you going through each of the articles or studies that were given as essential readings all the way through, or just skimming them or reading abstracts?
Yeah, it differs from week to week. I mean, sometimes we get a whole lot of articles to read, and some of them I just skim, because you cannot read 28 articles in like 10 hours. I mean, at least to me, every article takes about half an hour to read. So some of them I just read the abstract and figure out if I do want to read the rest. And some of the articles I read in depth, and some of them I just skim. Yeah, in the beginning I printed it all out because that's the way it's functioning the best to me. But then when the papers got piled up, I thought, well, this is going to be really a lot of waste of paper and ink as well. And then I tried to read it all just from the computer, and I marked it up and saved it on my computer with the markings. And I don't really have as good an overview as I did before, but then again, I may not be keeping those printed articles. So yeah, I think this has to be the way to me, because it's really a waste of paper the other way around.
Sure. Yeah. So there's that balance of how to organize your thoughts and keep everything to where it's easily accessible and go back to them when you're trying to then have some discussion, which we're meant to be active with, after we each make our summaries and post those.
Yeah, and you get kind of frustrated because you have so many files open at the same time on your computer. And then you have to write and read and remember, what article did I find that in? And who said that, and who meant what?
Yes. Yeah, certainly a challenge to keep everything organized. Talk a little bit about the content. I think the first couple of weeks we had looked at MDT assessment and we looked at some other topics. Now we've gone through quite a few more. Has anything stood out in your mind that's been novel, or at least you've expanded your knowledge about in the last few weeks?
Oh, yeah, on pretty much of the topics. And I think the topic we're having for this week, motivational interviewing, is really interesting and eye-opening to me as well. I kind of used it already in my practice just for this week, and think it's amazing to work with.
Yeah.
But the funny thing is that we are getting so much stuff into our heads. And if you ask me, so what did we learn 2 weeks ago? Well, I can't really tell you, because it's way back in my head now, but and hopefully someday I can find it again.
Yeah. Well, good. At least you've probably got some notes where you could go back a few weeks and find out.
I do. And if I look at it again, hopefully it'll be there quite soon again.
Yes. So do you feel like, you said you're working in your clinic in the mornings and then studying in the afternoons. Are you seeing yourself change in terms of behavior or your clinical reasoning developing at all, even while you're going through the theoretical with your patients?
Yeah, I do. But then I also get frustrated because some of the topics we're not really getting into too deep. And so if we're talking like an overloaded Achilles tendon, I know from the theoretical part that I can do something, but I'm not really totally sure about what to do and when to do what, because I haven't had it under my skin yet. I mean, I haven't had the practical of it, so I only get some part of it.
Right. And hopefully on the practicum, when we're with those patients and with our clinical instructor, we'll be having to apply it a bit more, and it'll hopefully all come together for us.
Yeah.
A lot to squeeze in just a short amount of time. So I can appreciate what you're saying. One of the big things that we're having to do as well is, yes, stay in fact up on our reading and also make comments, but we're also preparing for a larger project that we have to do at the end of the theoretical portion here. And that being a case study where we're going to be presenting and probably applying a lot of what we've learned and illustrating through a patient case. Have you got an idea of that patient and what you might be talking about?
Yeah, I've been thinking about several, and I think I picked the one by now that I'm going to use because, there's so many interesting subjects to write about. And I picked a patient who I felt very comfortable about working with. And so I feel I have a good overview of her. And that's important to me when I have to write the report as well.
Mm-hmm, mm-hmm. Yeah. So if you look back to your own thoughts about the program leading up to the theoretical, now having gone through a lot of weeks of it, the majority of it, what would you have done differently before to prepare for it? Anything come to your mind?
I would have been very happy to have the basic manuals and have read them very thoroughly, because when I did the basic courses back in the 90s, well, I think 90% of it has changed for the new manuals. So I would really have loved to have them and been working from them.
Yes. Yeah, that's a good point. We're referencing those a lot, of course. How about just your own planning of, would you have kept your schedule much like it is now? Or do you feel like you would have been better if you had changed your schedule and when you chose to work on the program versus being in the clinic?
No, that's working really fine. Actually, I started out working 20 hours a week, and that was good for the first 4 weeks. But then I think the amount of work in the study was getting less. And then I started to work 25 hours at my clinic.
Mm-hmm.
So I started to work more now.
Yeah. Tina, I've recently talked to a few of the recent graduates who've already completed the diploma program, including the practicum. And I've just asked them to give their experience going through it. And then how has that affected their current careers and kind of going forward? Where do they feel like it'll help them develop professionally? And they gave some specifics of how, and some of them described how they felt like right from the beginning of the theoretical, it was very valuable and they could see it influencing them in positive ways. Others said that, boy, when I went to the practicum, that's when I really saw all of these things come together. What are your thoughts about that? Are you seeing yourself see the benefits of the program? Or are you thinking, I'm hopeful it'll come together during the practicum? Or what are your initial thoughts?
Yeah, I'm definitely on the last part of it, that I hope that I'm going really to have it all brought together in the practical part. For right now, my everyday work has not changed a lot.
Yeah. Well, you were using MDT as your framework and as your approach to your patient care already. Is that true?
Yeah, but I was using quite a lot of other stuff as well.
Yeah. Gotcha. Very good. Yeah. Do you have any additional thoughts of just the frustrations or the challenges or the positives that come to your mind when you just think about where we are a little bit midway through or a little further than midway through the program?
Some of the frustration is that I thought we would have more time with the educators. And I truly think that's when I learn the most. That's when we are having the Zoom sessions with them. And unfortunately, we are not having that much of it. It's mainly self-study and discussions with each other. And that's good. But I think in the discussions, people are just repeating what we just read in the articles. And so not much new stuff is coming up there, I think.
Gotcha. Yeah, it's good insight, and I appreciate that. Yeah, well, again, we'll hopefully get through these last several weeks, finish up, and we can kind of touch back perhaps at that point, and then maybe even down the road further past the practicum, and hopefully we'll find that, yes, in fact, you feel like, okay, now it's all come together. But I'm sure it's like we learn with so many things, it's an ongoing thing, career long. But anyway, Tina, thanks so much for kind of giving us kind of a scoop of where you are now and just where your head is and how you're coping with these things. I think it might help others who might be considering the diploma program in the future, some more immediate than others. But we appreciate you kind of sharing your thoughts and for joining the podcast again.
Yeah, thanks.
More good insights from Tina. We'll switch over and hear from a couple of more. So back with us on the podcast for a little recap and perhaps an update within the mid-theoretical portion of the diploma program is good friend and colleague, Davide Castorina.
Hi, everyone.
Yep.
Thank you, Jason, for having me back.
Yeah, no, of course. And Tim Davis. Tim, glad to have you back.
Yeah, morning, Jason. Thanks for having us.
Absolutely. Thanks, guys, for having an interest to just kind of give us a little bit of an update on where we are and where you guys are in your mind and all with coping with all of this. So, Davide, tell us from your perspective, how are things going? We're kind of in the more than halfway through the diploma program theoretical portion. How are you coping? And tell us a little bit about just where your head is with all this.
Yeah, Jason, you're right. I think that 8 weeks are going really fast. We're on week 9 now, so it's crazy to think we're almost there to the end of this. And yeah, lots has happened, lots of learnings. And I think that compared to the first couple of weeks were pretty tough because it was really a change in the way that reading literature. You went from reading a paper maybe a couple of times a year and to having to read 20 papers in a couple of days and make a summary of them. So the fact that everything we had to mention had to be referenced to, I found that my brain was so overwhelmed. I think I had to reference everything I was telling to my wife as well. So we need a couple of eggs, according to who? Said, but for the first 2 weeks were like very hectic. But then I think as you start getting used to that, now I found my way to get around those, the way of reading papers. I mean, what those first 2 weeks, learning how to read literature was super helpful because I think that before you wanted to read every single line, it took ages to read one paper, but now you know what to prioritize when you have lots of readings as well.
Yeah.
And I think a big game changer was Anna's suggestion about the use of this software called Zotero, which is a time saver, and then that has helped me a lot in the way I want to write my comments to put the reference underneath. It saves lots of time. So there was a good game changer, I think, for that.
Davide, you mentioned two things there. Let's just give a listener out there a little bit of a hint. How do you now approach a scientific study? I'm going to put you on the spot and ask you.
Yes.
How do you look at it to get the information and move on in a concise and efficient way?
Yeah, I think that probably from one of my learnings, I can't remember him name the guy that quoted that, but what I was saying when reading the article, so, once you read your abstract, you can read the introduction, so you know what the title is about, and then you read the methods, move to the methods to see how the study was approached, and then I go and read the results to check that. So focus on the 3 first components, and then if I need to go in more depth, obviously I go back and read all the rest of it and the comments, etc. So from my lens, this is the way I currently doing that. Yep. And another thing that I found that, for example, if you need to comment on something, and I remember I've seen this somewhere, I probably go and open the paper, do a word search on that paper, which will take me probably to the point where I wanted to reference as well. So I think these are 2 key things that help me probably save time and be more focused on what I need from that article.
Yes. Yeah. Good points. And it has been helpful to do that and to read that suggestion. You mentioned Zotero. Anna put us onto that, one of our classmates. Tell the listeners what Zotero is.
Yeah, Zotero is this amazing software that you can now download free. And then what you do, you can obviously have your, it's hard to describe without looking at it, but you have your files and folders. For example, I go my week 1, week 2, etc. And then in each of those folders, you can add literature. So what you do, you find a paper that you need to study, either enter the DOI or another code into Zotero, and then that automatically load the paper on this software. So wherever you need to look at it, just go on Zotero. I got everything organized in my week. I double click on that and it opens up the paper that I want to read. So rather than me go on searching, what I do at the beginning of the week, I see all the essential reads that I need, and I load them in my week folder, and then I add to it as I find more references or more studies that I need for that week. Yeah. And what you need to do when you type on Word, there's a direct link between Word and Zotero. So, for example, if you mention something you want to reference it, you just click on the Zotero button, enter the paper you want, insert, and then it puts automatically the reference into the file there of what you're writing.
Yeah.
So really a time saver when I need to copy that into Schoology, for example, and without having me to type the whole reference once again or copy and paste it from something else. Because I used to find that hard to edit the type of character, the same number. So yeah, that was really time consuming for the first few weeks.
Yeah. No, it's a good resource to have. So we're indebted to Anna for that.
I always be grateful to her, and I told her many times already.
Yeah. So you mentioned that, you had to get in the habit of having a reference for everything that you mentioned in Schoology. I just wondered if, like, your wife is asking you to take the trash out and you think, well, actually, there was a paper done in 2000.
Yeah. You pretty much run those lines.
That's right.
In my head, those nightmares of Richard materializing somewhere else, according to who, for everything else. But no, jokes aside, I think that the shock the first 2 weeks, it's just I'm over that now. So always remembering that we spoke about now evidence-based medicine. Yes, papers evidence is important, but also sort of about also your own experience and also the value of the patient that you use. So I think there was a big learning of when we say, this is effective or this is not effective according to the literature, but always we need to make sure that we are right ones to carry that type of learning, and also that the one that receives it, our patient, is the right one to receive that type of learning. So even the most rated RCT can be not ideal for that type of patient. So I think that was a big learning. Sorry, probably we're going to be off topic now, but I think that was something that I really emphasize as well.
Yeah, it's a good point. Tim, tell us about your perspective. How are things going? Tell us a little bit about just where you are deep within the theoretical here.
It's been busy.
Yeah, I bet.
Yeah, just getting, I think like Davide mentioned at the beginning, it's pretty intense, but I think the last few weeks been getting a little bit more used to the workload and how best to efficiently get everything done. So it's been good just getting used to it for one thing.
Yeah, and I think, Tim, you were one of the few, if not the only, that's pulling a full 40 hours in the clinic on top of this. So even more so that makes sense why you might be a little busy.
Been busy.
Yeah, your life consists of sleeping and working and then the diploma program and not much else.
Yeah, for the most part right now.
Yeah. And any major adjustments that you've had to make? Have you altered in any way what you're doing, either before work or in the midst of work during a lunch break or just anything like that?
I was actually doing 410s before the program started, but I was lucky enough to switch it to 5/8 just so I'd have a little bit more time before and after work. Because if you wait too long, then everybody's comments pile up and then you get behind. So I figured if I could do a little bit each morning, each night, and then at lunch if needed, it's been a little bit more manageable than saving it a lot for like one day off type of thing.
Right. Gotcha. Yeah. Any major insights as to how you're approaching the comments? We're actually being taught things, we're posed with questions and topics, and we're meant to summarize, and then we're meant to comment on the other groups, broken up into groups and comment on other groups' summaries. Have you addressed that any differently as the weeks have gone on?
Well, definitely that citation manager Sotero was certainly a game changer, as you guys were mentioning before. I think now I've gotten a little bit better of a focus going into everything. So, initially at the beginning, I would kind of take my time and I'll do a little bit of this and that, but now it's, all right, what's exact the information that I need from the paper? What exactly is the question I need to answer for this prompt, and a little bit more focused on it just for efficiency. I think that's improved for sure for me.
Yeah. If you think back, guys, to where your anticipation or your expectation of the program was before we even started, was it a lot different than what it actually has turned out to be 9 weeks later? Tim, you have thoughts on that?
Can you say it again, Chief? I'm sorry.
Yeah. I'm just wanting to identify if what you expected the program to be is what it is, or has it now, having gone through 9 weeks, is it quite a bit different than what your expectations were?
It's different. There's probably more on communication than I was expecting, but at the same time, I think we absolutely need to be spending as much time as we have been on communication. So maybe that's been different, but it's been different in a really good way.
Yeah.
Just learning about how our words can impact a patient's outcome and their course of care and their need for, surgery, or we could have a huge impact on if they're going to be coming along pretty nicely, if they're going to be really prone to like fear avoidance behavior and things like that. So.
Yeah. So if a colleague out there that you knew somewhere across the states, somewhere or across the globe, reached out and said, "Hey, what's a paper that would suggest that maybe my words might impact this patient, or that the doctor's description of the patient's problem might impact in a negative way," where would you point that colleague to?
Well, I don't have it off the top of my head, but I can think of a few right now. They did the paper on just going through people with back pain with MRI findings. They either told them it was normal, age-related, incidental, or they told them like pathoanatomically exactly what was going on, and took a look at the outcomes, and people who were told it's age-related, it's incidental findings, had a lot less chance of a perceived need for surgery, continuous intervention. Another group didn't do quite as well.
Yeah, it's pretty remarkable.
There seems to be just more and more of that kind of a thing coming out in papers, though.
Yeah. Davide, do you have any thoughts on your expectations and anticipations of the program before we started? And in actuality, now 9 weeks later that we're into it, it's different.
Yeah, I think that I was expecting obviously lots of learning, which is happening. And I found that what we've done, at least in New Zealand, in the past 4 or 5 years, with all our seminar day, credential update dates, which were showing bits of this newer evidence. Obviously, this diploma is that on steroid, because you're getting all the latest papers, latest evidence. To what I found, and I didn't know much about this before starting, was the involvement in the small groups, which I'm really, really enjoying from one's collaboration point of view. So that's another skill I think that not everybody has, and also dealing with the other physios from different parts of the world, different cultural backgrounds too, and it's been a good learning as well, not just from obviously the physiotherapy evidence-based learning, but also from a social, and even if in the future, we started on some research, you have to collaborate with other people from different parts of the world. This is a great background to have. I think it has been very helpful for us all, and as well. So this is something that I wasn't expecting before then. So I really appreciate it from this diploma.
Yeah. Tim, tell us about any patients that you're feeling like, okay, you know what, I'm seeing that my clinical reasoning with my patients while going through this is actually changing, or my efficiency with patients. Have you seen any kind of transformation or any subtle hint of that happening? And maybe you have an example.
I think for one thing, I'm telling people they're going to get better, just a lot more often than I might have thought about doing before. Yeah. First and foremost, like if there's a pretty good sign where there's no big red flags, pretty soon, right out the gate in the history of it, you just mentioned to them that this is very likely to get better. Nothing serious is going on. And, if it's a shoulder thing, it's mind how the pain is feeling, but to keep using that shoulder in order to improve the stiffness as it's coming along. So I think that's been one thing for sure. I've been a little bit more mindful of since the start of this program.
Yeah, I think all of us kind of had that realization that, that's probably one of the number one things people want to know when they come to us is, am I going to be okay? And so simply just stating those words, you start doing that and you realize, oh, okay, good. I feel better about it already. And I think if you're not aware that that's one of the major concerns that people have, and you don't say those things, it doesn't mean that the reaction of their symptoms over time as they do what you ask them to do won't prove that to themselves, but just stating the words, I think, is pretty critical and pretty key. Davide, you're not in the middle of any patient care, I think, while we're going through the theoretical, but do you see your clinical reasoning changing at all, and in what way, I guess, when you get back in the clinic?
Yeah, I think that all the good points that these are effective communication and the way we speak to the patient being reinforced during this diploma. So what I find is that, like Tim was mentioning about telling the patient positive messages, or making sure that you avoiding those nocebo possible type of wording or language, which previously I was trying to be mindful of. I think they've been reinforced by all the learnings I've done, and especially in the last couple of weeks too. What I find though, with all this learning that we have done, and it is not to sound arrogant, but I think that sometimes when we confront us with other healthcare professionals that maybe don't think like we do, and then are based on, again, worrying on telling patient, you got this pain because you got a disc protrusion, or you're discussing that, or focus very diagnostic false blame. I found that that will be our new challenge once we finish this radical, and then, or even now when we go back to our dealing with other health professionals. So I find that sometimes you will feel a bit isolated if you are the only one that say, actually, no, there's lots of evidence that show that this is okay to have. Lots of people that don't have pain, for example, have the same findings that your MRI has shown. But if you're not backed up by the specialist or other professionals that tell the same, the patients could look at you and say, what the hell are you saying? But again, you can always show them that there is evidence around that we can back it up. And I think it's part of our purpose to try to encourage the patient, to make them feel comfortable, and try to improve the outcomes using appropriate language and showing them that what is always often connoted as negative is actually normal for majority of people in this world.
Yeah, right. Yeah. Yep. Communication is pretty critical. I think we all agree. What about from a management and a diagnostic standpoint? We talked about at one point, those contractile dysfunction type presentation, tendinopathy presentations. We've talked about differentiating between the cervical spine and the shoulder, all the topics that we've known that are critical when we consider, okay, where's this problem coming from? What's the nature of the problem? Does it have a direction that it needs? And then does it have a particular load, the amount of that, or dosage of that direction? You guys see your mechanical, or do you anticipate when you're back with patients that you're going to handle patients any differently? Tim, have you seen anything with that while you're in the clinic as well, rather than just communication?
Well, just as far as differentiating spine and shoulder, I know after I read the paper by Joseph Massio about, I think it's called Directional Preference of the Extremity, I'm definitely taking a little bit more time to make sure to screen out the thoracic spine, because I think it was like something like 70% of the people with upper extremity complaints had a thoracic component that wasn't revealed by just cervical testing alone. So I think I'm getting in there a little bit more regularly now, just to make sure I'm not missing anything from the spinal component. Yeah, that was interesting for me to see.
Yeah, I agree. Pretty critical. Davide, from a subgrouping or classification standpoint, do you see yourself handling things different at all? Anything that comes to your mind?
Yeah, I think that when Richard in our orientation week asked, what do you expect to improve or learn from this diploma? One of the things for me was, being able to manage the other subgroups, in a more, consistent way, or more, evidence-based way. And I think that with the learnings that we had so far, and especially in week 5 and 6, when we addressed those, and that's been very helpful to say, okay, the derangement, the dysfunction, how am I gonna manage this too, and making sure that we base ourselves, still basing on evidence-based papers and articles that guide us towards those type of other subgroups. Definitely now I know where to go and look for that specific patient, for example, and rather than, okay, I know that if I do this, I'm going to improve this function based on my experience. But I think that having the additional know where to look in the evidence too, that will add more value to the management of the patients for sure.
Yeah. Davide, you had some specific interest and study on concussion, I think, before this program. You've been working on that for a while. Tell us a little bit about that, and tell us maybe what the diploma program how that might interact or affect that particular aspect of your care.
Yeah. So I've been probably the last 7-8 years been developing interest in concussion, and then I became a vestibular physio and also work with the New Zealand Rugby, World Rugby, and as research assistant for some studies that have done on concussion management pathway based on rugby mainly. And I think in terms of the management and of concussion, even that's not a specific MDT topic or the range that we normally treat, but I think that all the learning about communication that we had in the past few weeks can definitely be related to concussion as well as other injuries of patients that we treat on that. So when we go and especially with concussion, especially treating high school kids or people that present themselves, come to the clinic with their families or caregivers, I think it's been good to learn also how to communicate with the whole network that they have around, so with them and with the schools, with the coaches. So I think having the same type of language that is consistent with all those stakeholders around the concussion patient, for example, I think that those communication learning that we had so far can be definitely brought into that.
Yeah. Yeah. Davide, do you find that there are, in that patient population, that there are some that present with symptoms that could be true concussion, but there are others that are misdiagnosed where that looks like there's maybe cervicogenic contribution and that those conditions almost mimic true concussion?
That's right, Jason. So, like you say, our head is supported by our neck. So normally if something happens to your head or to your neck, it's very hard to differentiate, like you mentioned, that they very show similar signs and symptoms. But doing a good and thorough assessment, which is part of the neck, for example, with my concussion patients, I use the McKenzie cervical spine assessment to assess them too. And often you notice that they are the ones that have been diagnosed with a concussion that can quickly resolve those symptoms working on their neck, because you identify there could be a derangement, often in the upper cervical area, for example. So when we assess for patients with concussion, the cervical spine is one of the things that we definitely go and assess on top of all the vestibular and bones, etc. But yeah, you're right to say that often treating the spine can resolve those problems that could seem to be concussion related. But always bearing in mind that, at least in New Zealand, the diagnosis of concussion is outside of the scope of a physio, so only a doctor can diagnose or clear them for them. So we do all the work, we do all the assessment, and then we can go back to the doctor and say, these are my findings, and you make his score then.
Right. Yeah. Hopefully they appreciate your contribution and recognize that you're a good diagnostician and not just a technician of administering exercise, right? Hopefully that's
right.
Relationship you're building with those guys. Excellent. Tim, we're tasked with finding a patient and doing a final at the end of the theoretical a presentation on that patient and incorporating all that we've learned. Do you have a patient or two in mind that you've already chosen, that you're considering?
Yeah, speaking of concussions, just a different kind of a patient that we don't typically see on a day-to-day basis, but one I've been thinking about had a bike crash and ended up getting a concussion, breaking a clavicle. So he was having vertigo and couldn't lift his arm past 90 degrees, flexion or abduction. So he was a month out of clavicle surgery and still couldn't lift his arm. Was having headaches, pretty consistent vertigo. If he were to bend over, look up, things like that. So he ended up having BPPV, which resolved really, really quickly with a couple Epley maneuvers. He was good. And then he couldn't lift his arm, but he also couldn't move his neck. So he did a few retractions and he could move his arm pretty full and free. So it was just a good one that made me think just a little bit differently, as far as there's a few different things these symptoms could be coming from, and just we want to focus it down just like we would on a normal MDT assessment, when there's a couple of different, vestibular systems to consider. We can do a similar thing as far as classifying patients with that kind of symptom as well.
Yeah. Sounds like a good case. We'll be interested to see that. Davide, any patient that comes to your mind that you've seen in the past that you started working on?
Yeah, from the case report shows a patient of mine that she presented to me a day after the injury with the arm pain.
Mm-hmm.
This was very interesting because she wouldn't want any will to move her arm. On day one, her neck pretty much was restricted in any movement because she wouldn't move it because say everything was producing pain on her arm. So very acute. And then as the day went on, things started improving. She saw, especially, she was sent for MRI of her shoulder, of her neck, and she got diagnosed. She had 4 different diagnoses for 4 different people at the end of the day. But she improved, she got better, and she returned to her previous level of function. But the point of my case work will be more on different aspects of what we learned recently, actually, because she, in the MRI of her neck, there were no disc changing, no findings. So the specialists say that that wouldn't be possible, that her neck was restricted on day one, or the fact that she didn't have any pain in her shoulder. Say, this definitely cannot be her shoulder. So I think that all those findings about the fact that there are patients that have pain even without diagnostic changes shown in that, and the fact that now we want to be patient focused rather than be labeling our patients with different classification, that would be at the end of my point. So I got lots of ideas that always will trim down and come in a good case report at the end of it.
At least we have more than 500 words we can include on our case report,
Yes,
right?
yes, that's right.
Well, anyway, I'm sure it'll still feel like we've got to be concise about it. But guys, if you could go back in time and encourage yourself or educate yourself on what you should or shouldn't worry about. Maybe you think back before the theoretical, I had this or that barrier in my mind about whether or not I can achieve this goal of becoming a diplomat or being able to get through this program where I am in life. What would you say to yourself? Tim, think back of any, challenges that were in your mind of, is this the right time? Should I do this? Is it worth it? And now 9 weeks in, what would you have said to yourself?
I think thinking back, I was definitely concerned about just am I going to be good enough to be able to do it? I think that was the main thing. So I think just listening to a lot of the podcasts on mechanical care forums, I hear these pretty high level clinicians talking on a regular basis. I'm like, all right, I think I'm kind of starting to pick it up a little bit. So I definitely got my confidence up for it, and just hearing them more and more, I think that's what kind of pushed me over there. Just like, yeah, I want to be on a similar level to those people because they're doing something right. So that kind of got me motivated to just do better. So,
yeah. Davide, any barriers that were in your mind, or at least thoughts about, is it the right time, or should I do this? Is it the right thing for myself or my family, or with my practice? Is it going to help me? And then 9 weeks later, now that you've seen what you've seen, what would you have said to yourself? Yeah,
I think that going back, I will tell myself that this was the perfect time to do it in my current situation. So I'm glad I did it now. For many reasons. My current work commitment is not the full-time commitment. So I like them. That is working full-time. I have more time on my hand, even though because my wife is not working, so I'm looking after the kids. So I got other types of commitment, obviously, in the end as well. But I think this is the right time. I think the right level of maturity, probably, of what I learned. Yeah, I could have done a few years ago, probably. But I think that going back, I will tell myself, yeah, you've done it right. This is a good time to do it.
Yeah, very good. Yeah, guys, we're usually trying to find or have already found a time and a anticipation of when we might go through the practicum, that total of 9 weeks. I think I'm tasked to go to Austin this summer, so in a few months. What about you guys? Davide, have you set a time and a plan?
Yeah, so I'll start my clinical practical when in July when I get back to New Zealand. I'm gonna split in three weeks courses. So I'll have one in July, one at the end of the year, and one at the beginning of 2024. So hopefully by February 2024, I will have completed the 9 weeks.
Excellent. And Tim, you had some discussion about that?
Yeah, it looks like I'll be heading to New Jersey in the fall. That'll be 9 weeks consecutive rather than the split 3 weeks at different times. I ended up working all right with, fortunately, the bosses at work were nice enough to let me go for that long.
Yeah, good. Excellent. Yeah, well, thanks guys for kind of give us an update of how things are going for you, how you're coping with the volume and managing it with family and with work and all. We'll reconnect perhaps down the road once we've gotten through and hopefully with some success through the theoretical. Tim, Davide, thanks for joining to share kind of where you are and back on the podcast here.
Thank you, Jason, for having us.
Yeah, thanks a lot, Jason.
Okay, so there you go with episode 394. I hope touching back in with this year's cohort is helpful to you to get an accurate impression of what it's like for this group to tackle this program. Stay tuned to catch my conversation with 3 instructors who contribute leading portions of the theoretical component, Yvonne Bodie, Grant Waddy-Watson, and Mark Cheel. This next episode, they'll share a bit of what they teach, their goals in leading the discussion on their particular topics, and a few nuggets which I took away from each of their modules. Be sure to subscribe to my email updates to be notified of new episodes. Subscribe to the podcast on your favorite podcast player and my other social media channels, as we'll be notifying you when each episode comes out. Again, we want to thank today's sponsor, the McKenzie Institute International, providing worldwide training and support to clinicians in the principles and practice of the McKenzie method for management of patients with spinal and extremity disorders. The McKenzie Institute Diploma program provides the highest level of MDT training. It enables clinicians to acquire an in-depth understanding of the McKenzie method and become experts in its effective use in guiding their patients to achieve their personal goals. If you have an interest to learn more about it, check it out at mckenzieinstitute.org. And don't forget, we're continuing to plug away here at Mechanical Care Forum with new cases within Case Conversations, our patient case discussion resource, and new scientific studies within Inside the Science, our peer-reviewed summary and discussion resource as well. These are intended to provide some virtual mentoring of sorts for you and help keep you moving forward in your professional development. You can check out these at mechanicalcareforum.com. All right, I wish you a great week with your patients this week. Have a relentless pursuit of professional growth, whether through the MDT Diploma program or other means, and find balance. And join us right back here next week for more from Season 13 and sharing experience for improved patient care.